since it's a voiceover, are we okay with this? And then I won't, that's what we did last time, so we didn't have to worry about it coming over the top. All right. So, at the musculoskeletal, so this affects everybody you know. And this is, to me, one of the easier systems to do because it's the obvious. You're going to see it on your patients so much easier. As far as, we've got a nice normal vertebrae, okay, on the left. So, do you see that one on the bottom there, bottom left? And then osteoporosis on the right, so that bone density is just gone. Primary things we're going to do this chapter is cellular regulation and then mobility. Okay? As far as the cellular regulation, we'll see the osteoporosis, or we'll see bone tumors in the young adolescents, or bone infections and deformities. And those all happen with that cellular level. And what it's going to do is going to affect their mobility because they are in pain, okay? And they're in pain. Sometimes they don't have enough blood flow to that area, enough perfusion, and so it's impaired. Common and contrasting characteristics. You always ask your patient's history, right? It'll affect this. You know, there are going to be some things that are going to be genetics that are going to affect your bones. Their culture, because that's also going to have a play on what they're doing, where they are, and their diet. You know, like you said, osteoporosis is definitely one with the diet. You will be able to see things, physical signs and symptoms on the patient. Okay, cellular regulation causes decreased bone density and possible fracture. Osteomalacia is the lack of vitamin D, which causes softening. If we don't have enough vitamin D, it causes softening. Bone remodeling is the living, changing tissue. Osteopenia, the loss of bone mass. And the bone mineral density is the amount of minerals will determine the strength. And a lot of you are right there, or almost there. Your bone strength peaks at 25 to 30 years. Okay. When we think about our cellular regulation and the decreased density, it puts the patient at a possible risk for fractures. Because those bones are fragile. Females with the hip fracture are at increased risk 2 times over men. But men typically die more. Hip fractures increase your mortality within 6 to 12 months. So if you hear somebody say, oh no, they got a hip fracture, oh, you're thinking, okay, we can fix that surgery. But if it's an elderly patient, typically they have definitely an increased chance of mortality within that first year. Cancellous or spongy bone is always lost first. Then they're going to lose their cortical, the compact bone. So cancellous is the spongy bone. Then they lose the cortical, which is the compact bone. You'll notice this first in the hips, in the wrists, and the spinal column. All right. Look at that beautiful spine there. Normal spine, somebody at 40. 60, and then 70. We were talking about, does anybody remember what this little hump right here is?
Kyphosis.
Kyphosis. Yep. Okay. This talks about at least 6, it can be as much as 6 inches in height. Okay. So osteoporosis is generalized. It's primary female, post-menopausal. In males, it's the 7th and 8th decade of life. Secondary osteoporosis is other medical conditions caused by their osteoporosis. Okay? A lot of people will use corticosteroids because then they can, it'll keep their prolonged decreased mobility. They can keep them going. Spinal cord injuries. If they have regional osteoporosis, instead it's localized to one area. The limb is immobilized, which could be like a fracture. They may have a brace or paralysis. What kind of things can we do to help prevent osteoporosis?
Increase vitamin D and calcium.
Vitamin D, which is going to help us be able to absorb the calcium, right? What kind of other things can we encourage people to do daily? Exercise, okay, and weight bearing. So like a walking. Do we encourage running for osteoporosis? No, increases their chance of breaking. Smoking cessation. Smoking is a very, very bad thing for all body systems. We got to limit their alcohol. We don't want them to get impaired and then fall and break, right? No. Plus, it's for absorption, right? We don't want them to fill their calories with that instead of something better. And decrease your carbonated beverages. Alterations in the growth hormone itself, they have found in petite Asian American women. So the little tiny, tiny women are the ones that have the most problem with this. All right. Nutritionally, the calcium loss will increase with high intake of phosphorus. So they do not suggest soda-wise. Anybody have any idea? A large intake of soda, they do not want you to have over 40 ounces of a carbonated beverage per day. Puts you at high risk.
As phosphorus increase, calcium decrease.
Calcium loss increases with phosphorus decrease. Yep. Calcium loss. So if calcium's going down, as phosphorus goes up. Okay. There are protein deficiencies that affect the calcium, and 50% of the calcium is bound to protein. What is a gravity-free environment? Can you think of somebody that works in a gravity-free environment that would be at risk for osteoporosis in a localized area? Astronauts, there you go. You don't think of them with osteoporosis, but yes, because they're in a gravity-free environment and they're not doing the weight bearing. Yeah, it does, but it's not something you would just think of. Okay. So we're going to do a fall risk assessment on these people. We want to see what's their chances of falling. Falling, you're going to break things, potentially. Okay. As far as we've talked about the humpback, we saw kyphosis, and the book said 2 to 3 inches. Our slide said 6 inches within the previous 20 years. The most common spinal fracture is between T8 and L3, or the upper third of the femur, or the distal end of the radial wrist. Okay? Those are our most common fractures. Calcium should be, what's our normal range for calcium in the body? 9 to 10.5. Vitamin D, we're
No. 8.5 to 10.
8.5 to 10. Okay, your textbook says 9 to 10.5. I'll take 8.5 to 10. But we're putting it right in the range, right? We are right there, though. So that puts them off a half a point, right? 8.5 or 9 to 10 to 10.5. What's it? Are you Googling it for me?
I'm not, but I can. That's just what we were, I think, right? Okay.
See? That's good, because this textbook, the new textbook here, says 9 to 10.5. Okay?
It says 8.6 to 10.3.
So it's right smack in the middle of the other two, between what you've been given and then what this textbook says. All right. So 8.5 to 10.5 would cover all, right? Okay, vitamin D. What kind of levels do you have for that? What would be our normal lab test for that? I have 25 to 80. Okay. All right. When we're talking about, so those are the laboratory tests we're concerned about. The dual X-ray, the DXA, they like to do this in females in their late 40s for a baseline to see where they're starting. And what that's going to do is check that spine, hip, and wrist for the bone density at that point. So we're looking for the volume of bone density and the strength of the vertebral spine and hip. All right. Biggest problem is potential for fractures due to weak porous bone. So we just want to avoid fractures, prevent falls, manage the risk factors, and adhere to preventative treatment. Can somebody give me just one thing you would want to do in an elderly, tiny female's home? She's living on her own. What would be one thing you would want to do in her home to prevent a fall?
Take the rugs out.
Take the rugs out. There you go. Take the rugs out. You got everybody?
I think so.
Sweet. Thank you. Okay, planning and implementation. So we were talking just a minute ago about safety precautions, so take the rugs out. Absolutely. Drug therapies that we can do for these are biphosphonates, because those slow bone resorption and they help form new bone tissue. You want to avoid excessive alcohol and caffeine consumption. We're going to eat and drink calcium and vitamin D foods, especially ones that are enriched. Typically now we have it in our milk and bread and orange juice and cereal. So we have a lot of things that are already done for us. Okay. And the other thing is they need a variety of nutrients. Not just the calcium and the vitamin D. So we have to make sure that they've got fruits and vegetables and low-fat milk products, protein, and increased fiber. Things that we don't want, like you heard, no tobacco. Post-menopausal women over what age, typically? Over 40. And post-menopausal men at what age? 70 to 80s. And it can happen as early as 50s. And we want what a minimum, how much calcium intake did we want? We looked at that chart last week. So on average, you would want at least over 1,000, if not 1,200 milligrams per day. What kind of physical therapy, what kind of exercises? Weight bearing and strengthening. So they can go to the gym and they can do light weights, different repetitions. We want to make sure we keep the abdominal muscles in the back because we want to keep their posture improved. and we have to support that spine. Swimming is excellent, and so is yoga. Has anybody ever been in the YMCA and you see these little ladies come in? They're there for yoga class. But it's done so much better. We have a lot of younger people coming for yoga too. And so no running and no horseback riding. Okay? That's another one. It's not a good thing. Okay, osteomyelitis. This is nasty stuff. This gets very, very difficult to take care of. So it's an infection in the bony tissue. And it's getting in there to take care of it. So this can be caused by bacteria, viruses, fungi, or parasites or maggots. Has anybody ever seen maggots in a wound? Have you? Mm-hmm. Yeah. And actually sometimes that saves the patient, right?
Yeah.
It does, because it's eating off some of that necrotic tissue until we can get them the right help and get it cleaned out and get it dressed. And yes. So sometimes you have a patient come in the ER and they have, you can see this wound. They may have a bunch of flies or they may have actually maggots. But sometimes that has actually saved them because it's eating away that infection for them. So as gross as it is, it's like, oh, okay, it can do the trick. So exogenous versus endogenous. Exogenous, endogenous. So those are our ones outside the body. The endogenous are the ones carried in our bloodstream. And what the problem is these microorganisms stimulate the inflammatory response in the bone tissue. That increases the vascular leaking and edema in the blood vessels. With that increased volume, it becomes pus. They release pus into the bony tissue and it becomes necrotic. So that is why we can't let that bone die. A contiguous bone infection is from the skin infection of adjacent tissues. There was a clinical patient last night. I don't know if you had him on day shift. He was a motor vehicle accident that had a nasty cellulitis of his left foot. But the bottom line is he had so many scabs and things all over that I could see that coming from infection, that it could be a contiguous, from the skin on down. Did anybody have him on day shift? Did you? Okay, so you had him. So can you, he would be the perfect example. Did anybody else in your clinical group get to see him? Sarah did? You think about it, he had all these issues on his skin, but if they weren't treated, and he had a huge medical history that this guy, there were so many things to treat, it was kind of like, where do you start with them? So he did. So let's see. You were in that room too, weren't you, Holly? Okay, I was thinking. Yep, he was pretty much a mess. And at one point in time, we were in there, I was concerned that he was getting septic because his respirations at one point in time were up to 32. His temperature was dropping. His heart rate and respirations were going up. I'm like, is this guy getting septic on us? He might, yeah. He didn't look good for a while, but he got better.
He was normal the whole time I was there, or his vitals were.
His vitals were? Make sure this is on. Okay. But he would be a perfect example of this. Okay, so we have acute osteomyelitis versus chronic osteomyelitis. The acute is usually a bacteremia, is the underlying disease, and it's a non-penetrating trauma. A chronic osteomyelitis is misdiagnosed or inadequately treated, like foot ulcers, or it could be salmonella to the GI tract, and then it will go to the bone. Patients with sickle cell anemia. Where do I want to go? A lot of people don't think about poor dental hygiene. So they can get periodontal disease, periodontal infections in the gums, and then it can go right into the bone there. Some people get these after surgery. So it can be most common is MRSA from surgery implants. And even older gentlemen, and it's males in particular, if they have a UTI, it can spread to the lower vertebrae. So these people will need long-term IV catheters. You know, they'll need PICC lines to get this, but long-term IV catheters can also be the primary source of an infection. Things I want you to look for is bone pain or a fever over 101, swelling, tenderness, redness, and heat. So that's in an acute system. If they have a chronic osteomyelitis, it's harder to determine because they have less symptoms. They've dealt with it so long and the body doesn't respond the same. Those are the foot ulcers, bone surgeries, localized pain. So with the chronic, the vascular compromise is severe. They don't, and a lot of them don't have pain. And that is due to the nerve damage from a lack of adequate perfusion. Okay, the ESR, their SED rate. Anybody know what that happens with osteomyelitis? It's going to be normal at first, and it's going to increase. It's going to increase as it progresses. They'll have an elevated white count. It takes a minimum of 4 to 6 weeks of IV therapy, and they have to do it at the specific time. It's very important you do it at the specific time. If they have a chronic osteomyelitis, they will do over 3 months of IV antibiotics. A lot of times you are teaching the families how to do these IV antibiotics at home. Okay, one of the things that Maza got to do yesterday in the pain clinic, or I'm sorry, not pain, wound. Who else in here has been to wound? Okay, that hyperbaric chamber. All right, and what's that going to do? You did a good job of describing it yesterday, Maza, would you?
Increases like oxygen that the patient gets, and that will stimulate like healing.
That oxygen goes right into those tissues to promote healing, correct? It's very helpful with the anaerobic infections. A lot of these patients, what kind of precautions are they going to be on at the hospital? What kind of isolation precautions? Contact. So do we have to wear goggles for that? No. Gloves and gown. And unfortunately, I will tell you that with COVID in the hospital setting, we needed all the gowns we had for COVID. We had such a shortage of gowns. And MRSA just kind of got left by the wayside. It was horrible. And so those people, other people that were in the hospital, like you said, you don't want to be in the hospital because you don't want to catch COVID. But if you had somebody that had MRSA and it got carried from the other room because you weren't being, it was not as protective of an environment. So that did change and go back once we got gowns, but when we didn't have enough and we were reusing gowns, the only patients that had gowns were C. diff. So, yeah, just a sidebar note on that. A lot of times we do an I&D, incision and drainage on these people. They'll have lots of wound debridements and bone excisions. Sometimes they will, if they can open them up, they will do, you'll see that they can do IV antibiotics, but not just liquid antibiotics. They will go ahead and flush that wound. And if we can't get the bone to heal in the necrotic tissue, they will remove it surgically, and then there will be a cavity or a hole. And sometimes they have to replace with bone grafts. The most common sites you would use is the fibula and the iliac crest. What do we really want to be looking for on these patients if it's anything in an extremity? Blood clots, okay. The assessment you really want to know, that's correct too. Blood clots, because they're not moving. Anybody that's not moving adequately. But their neuro assessment. I'm going to show you a picture, unless I just lost it. Hopefully I didn't. Okay. I'm sorry I don't have a bigger picture of this. But my son, and this is from him, I'll show you too. He had a guy come in to the ER, and he had a dog bite. This dog bite took off his toe. Okay? They put Scooby-Doo on there, he put ruh-roh. You know? So there's the bone. Look at the bone is gone. Show you guys this. Everybody. Sorry, I don't have a bigger picture.
Who was your son?
Huh?
How old was your son?
He was probably 28. I think he's 29 now.
The dog took off his toe?
No, it's patient. My son was working the ER. Podiatrist.
Podiatrist.
Sorry about that. So podiatrist. Sorry about that. Ruh-roh, Shaggy. Now, this is what it looked like. And he put on here, when your dog thinks your foot is a Scooby snack.
Oh.
Now this
You don't
guy,
get the dogs that eat you. Those are the ones you don't
I'm
try.
telling you, so this was in December. Isn't that amazing? But why did this happen to this patient? He did not have any feeling. He woke up to the dog. He slept through it.
There's also something wrong with that dog.
There's something wrong with the dog. Why was the dog attracted to this?
Exactly.
Because he had an infection.
He had an infection. And that caused the stink and the smell, caused the dog to be attracted to it. I mean, yeah. And so he woke up to his toe being gone and this dog chewing on his foot. Isn't that crazy?
He had to be a diabetic, right?
He was not. He was not a diabetic.
Neuropathy.
He had neuropathy regardless. He had neuropathy. So, but I mean,
Undiagnosed diabetic?
no, not quite, because that's what I was like. I asked my son all these questions, like, no, Mom, no. So yeah, it was quite something. I've got a few other pictures from him too that we'll show today. But yeah, I was like, oh my. So he sends me fun things like that when he's doing stuff. All right, so we talked about bone pain and fever, and the IV therapy. So how long is it if they're chronic?
46 weeks.
Mm-hmm. And how long is it if it's acute?
Again, 3
4 to 6 weeks typically.
For acute.
Chronic for acute, and chronic is over 3 months. Okay? And acute has a lot of that bone pain and fever. Chronic can have bone pain, but it's not, it's not something new, so they don't think as much about it.
I have a question. So
Sure.
That patient, did he tell you he had like a bone spur that was sticking out of that? The cellulitis?
This patient, my son,
No. The one from yesterday.
the one from yesterday. Okay.
Did you see that?
The bone spur,
He said he had a bone spur and he like pointed at it. I couldn't like tell because there was like
so much swelling.
constant drainage and stuff.
He
But
didn't-
would that have caused like been an increased risk for this? Since if it was there, I couldn't tell.
If there was a bone spur,
He
it
said
could
it was like
increase.
sticky, usually stuck out in the skin.
But I think the
I didn't
car
really think I
accident
saw
took it off.
anything. It's
I didn't see that. I think it might have been too swollen at that time. I mean, Jesse from Wound Care came in and he was like, I mean, that whole leg was red and fiery. It was, and it was swollen, the whole thing. And after you left, that foot just blew up like a balloon. I mean, so say your toes are here as you come up, okay, and this would be the heel under here. Like right here, one foot was like this at that point on the body. And on the other, it was about like this. That's how much he was swollen. It'll be interesting to see if he gets to keep it. Yes. Yeah. What's that? That was his foot. So like I said, it's like if your toes, my fingernails are his toenails, and this is the heel right here. About right, like 2 inches up. And on one, if the circumference would be like this on his regular foot, and the other one was like this. I'm not exaggerating, am I? It was.
It might even been a little bigger.
I don't think.
You think he's going to lose from like the calf down or just the foot?
It depends on the vascularity and how much they can keep alive. Okay? But I would be surprised if he stayed there all night though. Just because, like I said, I thought he was starting to get septic, and I actually told the nurse, I ran her down and said, hey, we're good.
We had a situation at Orange Jewish Psych Unit. A man who was mentally ill was wandering downtown. It was a night. He got hit twice. He had 2 fractures. They repaired the fractures. He was to stay on bed rest. He was non-compliant. They wound up having to commit him over to a psych unit. I could smell the decay when I walked down the hallway at psych. You don't smell decay in a psych unit. They wound up having to commit him and take his life. So the staff was in about it. But he was necrotic and he was going to be sacked.
There are certain smells you will learn right away, and that's even through an N95. Right? The other one, you will smell that, you will smell a GI bleed. Once you smell that, you won't ever forget that one either. Let's put it this way, I had a patient on Friday, it was my patient with a GI bleed, and his wife came, she walked in, she's like, oh, and she had to step out of the room. I said, are you okay? I will be. And she left, and she came back and she said, I put stuff in my nose. I don't know how you girls do that, but I stuffed tissues up in my nose so I can't smell this as closely. Because it was that bad. And then later on, when I had to get him up back to the bedside commode, I was giving this gentleman blood. He was bleeding out pretty well. He was in ICU. And he started to get up to the bedside commode again, and his wife said, I think it's time for me to go to Walmart. She was gone. I'll be back. She was gone another couple hours because she just could not handle the smell. At the end of the day, the intensivist came over. He goes, I bet you just wish you had COVID all day so you didn't have to smell. I'm like, it's bad, but I'm okay with it, So yes, you will get smells and you will get accustomed to different things. You will know as soon as you enter the room. Or if you're working in the ER, you already know. Right, Nadia? Yep. You know, like immediately that something is going on. Because it's not a smell that you can take care of. All right, let's go on to bone tumors. So we have benign versus cancerous. Okay, benign ones are often asymptomatic, and they can be discovered on a routine x-ray or as a cause of a fracture. Thing with bone cancer is the patient has a ton of fear, and they should, because they're losing control of their life, and it could be very fatal. The most common places for these fractures, of course, are the femur and the tibia. Young people, ages 10 to 30, have a small amount of bone cancer. It does happen. It does happen. I remember one of my sons was 1, and we had to get a surgery done that we knew was a birth defect. and he was in surgery for 6 hours. And these people came back that you're in this waiting room, and you don't know what anybody else has. And actually, I saw him on the elevator. I was getting on because I went down to get some lunch. And they said, "You're still here?" And I said, "Yes." "That you were here before us?" I said, "Yes. My son's still in surgery." And they were like feeling bad for me. And instead, they said, "Well, ours is done. Our son has bone cancer." Yes. And it was just like, I'll take that 6-hour surgery. Mine's getting better. You know, mine's going to be fixed. But that bone cancer you can't fix. So that just knot in your stomach is difficult. Okay, metastatic lesions are most common in the older age group, but metastatic lesions happen most in bone cancers. An osteosarcoma is the most common primary malignant bone tumor. And over 50% of the osteosarcomas are in the distal femur. This can cause acute pain and swelling, warm. It's really warm related to the increasing blood flow because it's feeding that cancer. Okay? If they have cancer in the pelvis, it is a very poor prognosis, very poor sign, because a lot of times it will extend into the soft tissue. They have found in the children and young adults that males have a bigger risk of cancer than females. Chondrosarcoma is a dull ache and swelling, but that's what they have, but a better prognosis, the chondrosarcomas. The Ewing sarcomas are not as common, but they are the most malignant. So they have low-grade TIMPs, leukocytosis, fatigue, pallor, anemia. Okay? Not fun stuff. Cancer hits the bone. People are usually in bad trouble. Okay, our benign bone tumors. What are we going to do for these people? We're going to make them as comfortable as we can. So non-drug pain relief measures. Can you give me an example of a non-drug pain reliever? Massage. I love massages. Massages, music therapy, aromatherapy, things like that. And the drug of choice for these are analgesics or NSAIDs. And they can have NSAIDs because it's not their GI tract. Remember, we can't give any NSAIDs and anybody with a stomach problem or any GI tract problem. You might want to remember that. So we're going to give it NSAIDs for pain, but not with anybody, but if not if they're pregnant and not if they have any GI symptoms. Okay. As far as surgical treatment, what we can do with the joint replacement, what they'd be doing is it prevents further bone destruction, and it might improve the patient function. Sometimes we do palliative care versus a cure for these people. What I mean by palliative care, did anybody in here know what palliative care is? It's a huge thing in hospitals that physicians are just now coming on board with. Okay, you've heard of hospice, right? Hospice means that we think the patient is going to die within the next 6 months. We can send them home and we can give them all the things they need and the meds they need to be comfortable. Palliative care is you have a diagnosis. Doesn't mean you're dying from it. But palliative care is you've decided you're not going to make a big change in your treatments. You don't want to keep coming back into the hospital all the time. So basically we give you what you need to live at home. The palliative care can go 2 to 5 years. You know, it can last a while. So you have a chronic CHF or congestive heart failure. That patients, if we get them in palliative care, that can prevent repeated admissions to the hospital. They'll have somebody checking on them, making sure that they're following their routine, instead of nobody checking on them, and then they ate a bunch of ham, they increase their swelling and all the fluid in the heart, that type of thing. So palliative care will keep this patient out of the hospital, keep them comfortable. Okay? Now, that's if they choose not to do further treatment. Let's see here. CTs and MRIs is how we're going to diagnose these. And the metastatic lesions will either increase or decrease the bone density depending on if you're doing the osteoblastic or osteoclastic cells, which ones are up. They will do a needle biopsy on the bone to stage the biopsy to see how late we're getting there. Elevated alkaline phosphate levels will happen, and their SED rate will increase related to the a secondary infection of that bone. A lot of times you'll see a rating of a scale TNM. So that's the tumor. They're rating the tumor, they're rating the nodes, the lymph nodes, and they're rating the metastasis. Okay? For pain relief for these people, what can we do for pain relief for these people? Besides the NSAIDs on the ones with bone cancer. There you go, radiation, chemotherapy. So that causes pain relief for them, and it will shrink the malignant tumors. And you can do chemo with or without radiation. And what is chemo basically? Anybody know? What's chemotherapy? Chemotherapy is a killer. It's going to kill the cells of the body. What we hope to do with chemotherapy is kill the cancer cells, the bad ones. But along with that, it's killing good cells too. That's why nutrition is imperative for these people on chemo. Okay, and what we're going to do. What do you think the psychosocial resources, what do we need to do for these people? We need to keep that in mind. We're going to need to make sure, do they have something for depression? Do they have something for their mood? Do they have anything that we can help them with? I don't know. Anybody in here think they wouldn't be depressed if we were diagnosed with metastatic bone cancer? I mean, I think that would be almost everybody. Like I said, they can use radiation for pain control to give a better life. All right. Let's just stand up and take a break for just a few minutes.